We're going to start this free paper winners presentation. I think to save time, we can have presentations on both the podiums. So first presenter is Dr. Pratibha Devi Nivian. Is she there?
Yes, sir.
Yeah. Meanwhile, can I have Dr. Chavi Gupta on the other podium? Audiovisual, please make arrangements on the both podium. Yeah. Dr. Pratibha, she is going to talk on, she is the winner of AIOS Sujata Savitri Rao Award, joint winner, and she is going to talk on tier biomarkers in thyroid eye disease, first Indian study. Dr. Pratibha.
Good morning. Thank you, sir. I thank the organizing committee for giving me a chance to present my project again in this podium. So, my study was on tier biomarkers in thyroid eye disease. It was a first Indian study. Sir, not move. So, thyroid eye disease, as we all know, is a complex autoimmune disorder. Understanding about the pathogenesis of thyroid eye disease is currently evolving a lot in terms of molecular aspects. The basic pathogenesis behind thyroid eye disease is autoimmunity. Due to inflammation, due to a trigger of inflammation which attacks the orbital tissues, there is antibody production against the self-antigens, which causes lot of fat proliferation, which causes a type 1 disease, and or a fibrotic change which can cause a type 2 disease. Thyroid eye disease can vary from a simple presentation with an inactive disease as in first picture to a very dreadful scene as in the third picture with lot of exposure keratopathy and a vision loss. So current scenario, what we do is we diagnose the disease, we do an activity scoring, we do a severity grading, and we treat the patient with steroids or immunosuppressants or radiotherapy or targeted therapies. But most of the people who treat thyroid eye disease will know that treatment of thyroid eye disease is not as simple as we explain in PPTs. It is very difficult because they keep recurring, so the management is very challenging. So what could be ideal is to identify the patients who will probably develop a very severe disease or an active disease before the onset of the disease. So we decided to look for any biomarkers that could tell us that this particular patient will have a severe or an active disease. So where all we can look for biomarkers, we can look in blood, fat, urine, and people have worked on even feces. But I chose tears as it is non-invasive, simple, and it is easy to procure. And I did some literature search and I found that there were a lot of interesting articles on tear biomarkers in thyroid eye disease as well. And this particular review was very interesting, and they had downlisted few cytokines, inflammatory markers, which were elevated in thyroid eye disease. So with this backup, I decided to go ahead with the study. We decided to look in for significant markers in tears causing thyroid eye disease. It was a pilot project done after ethics clearance. We diagnosed patients with Gorman and Broadley criteria. We did the activity scoring with Visa, and UGOGO was used for severity grading. Tear samples were taken from 2 centers, and the methodology was uniform in both the centers. The tears was procured using Schirmer strip, and it was transferred to another tertiary care center for analysis. And we collected samples of tears from healthy controls, patients with thyroid dysfunction but no eye disease, and patients with thyroid eye disease. We excluded patients who were not willing for the study. We basically did multiplex ELISA and looked for inflammatory markers. We chose 14 inflammatory markers, cytokines, for this study. We had 19 patients with thyroid eye disease and 11 patients with thyroid disorder but no eye disease. We had 11 patients with inactive thyroid eye disease and 8 active patients. In our results showed that basically the inflammatory markers were elevated compared to the healthy controls in most of the among the cytokines, but we found that interleukin 6 and interleukin 10 were significantly elevated in patients with active thyroid eye disease. And we also noticed that the intraocular pressure was significantly elevated in patients with thyroid eye disease and dysthyroid optic neuropathy. On retrospective analysis, we also found that there were other interesting literature which have been reported that interleukin 6 antagonists have been used for the treatment of thyroid eye disease, like tocilizumab. And there are so many specific target antagonists for all these interleukins, which have been successfully being tried for thyroid eye disease. But they were all pilot projects, but many are under trial basis also. So the future could be a biomarker detection can give clue as in who could succumb to the disease, and it also can give clue about the potential markers, and we can treat them with the specific antagonist early so that they do not go in for a very severe active disease. So to conclude, your biomarkers can be promising clue to diagnose patients at risk of developing sight-threatening complications. I would like to thank the people who helped me throughout the study. Thank you.
Yeah, very nice study, Dr. Pratibha. But how do you ensure that these biomarkers, like you said, interleukin 6, interleukin 10, they are not specific to thyroid eye disease? They may be increase in some other inflammatory eye diseases also. So how do you, is there any way to differentiate?
Yes, sir. You rightly said, sir. So any ocular inflammation, any ocular surface disorder will also have a raised interleukin. So how to be more specific? I'm continuing this study with orbital fat and comparing also. So that might give me an answer for that, if whether it is same or not.
Thank you.
Thank you, sir.
Yeah. So as Dr. Chavi Gupta starts, can we have Dr. Mihir Kothari on the other? Yeah. Yeah. Dr. Chavi is going. She is going to talk on novel and inexpensive training model for teaching basic steps of oculoplastic surgery.
Good morning, everyone. Thank you for this opportunity. And just like to introduce my topic. So we all know that ophthalmic surgical training has a very steep learning curve, and we require large numbers for increasing the stepwise surgical competence. And we had Halstead's model, who was from John Hopkins, who said that see one, do one, teach one. But here we have the patient safety, which is at risk. There are cadavers, but they are limited. They are bound by ethical concerns. And we have synthetic models and simulators, but they can be expensive and inaccessible. So for ophthalmology residents and ophthalmologists proficient at some must-know oculoplasty procedures, we wanted to develop a tool to assess the utility of pig heads as a potential surgical training model for surgically naive trainees for practicing steps of common oculoplastic procedures which are a part of the NBE curriculum, like upper lid entropion surgery, evisceration plus minus implant, and lid margin tear repair. So the methodology was hands-on training session which was held using pig heads in a controlled wet lab environment. We procured the pig head, established workstations, had didactic lectures explaining and showing the videos of the surgical steps which were broken down, and step-by-step guidance and supervision by the expert oculoplasty surgeons were given to the trainees. So I'll be talking about the surgical steps. The photos that you can see above are actually the human photos, and down below you can see how that can be achieved in the pig models as well. So all the surgeries were divided into their key steps, and they were achieved on the pig models. So this was entropion correction with margin rotation, where you apply the traction sutures, give incision, do subtarsal dissection, and put everting sutures. And this was the outcome on the pig model that could be achieved. And similarly, evisceration plus minus implant was done, and it could be nicely mimicked on the pig model, and even an implant could be placed in the intraconal space. Coming to the lid margin repair, here also it could be mimicked, where you give an incision on the lid margin, you help the trainees identify the gray line, help oppose the lid margin, and practice the lid margin forming sutures and the skin sutures. So to assess their performance in the workshop, we had a subjective assessment which was based on a Likert scale. There was a questionnaire for the faculty to evaluate the trainees, 3-point scale, whether they could perform the step, had difficulty, or could not perform at all. And similarly for trainees, we had for tissue feel, how they felt that their skills improved, and about the surgical steps. Also, for objective assessment, we developed a competency-based surgical assessment rubric specifically for entropion correction with marginal rotation, which was vetted and validated. And these had 5 key steps of surgery and 5 global indices, which are based on the OSCAR system. So this is based on the modified Riffus model. and has numerical tracking system, descriptive narratives, and scores for performances. And eventually, this surgery was then carried out by some of the selected workshop candidates in the OT within 2 weeks on real patient and evaluated using the same rubric. So this is actually the rubric that we had developed and that was used. And we had about 18 participants, which comprised of residents and ophthalmologists. And about majority of the participants had never performed these surgeries independently. So coming to the subjective scoring, we could see that majority could do the steps, and they had some difficulty in passing the horizontal everting sutures, but that could be managed with some assistance by the faculty. And similarly, the performance was evaluated for each specific step of surgery, for evisceration plus minus implant as well, and similarly for lid tear repair as well. So you can see that majority of the participants were able to perform the steps of surgery on the pig model. And when we took the assessment from the trainee side, they felt that the texture and tissue maneuvering was similar to the human eye. They felt that the practice on the head would make their surgeries more helpful on the human eye, and they had a better understanding and confidence of the surgical steps. For the objective scoring, that is the rubric, in the validation process, we achieved a score of 4. For the participants, it was about 3. And when it was taken in the OT, it was 4 again. So this helped when the participants actually performed these surgeries on the patient. They could focus more on points like hemostasis, patient cooperation, and they could overcome the apprehension. So usually what is an ideal model for surgical training? It should be available, it should be easy to dispose, inexpensive, and should be free from disease transmission. PIG model has priorly been used in selective oculoplasty surgery, some glaucoma and cataract surgery training, but this was the first study that has utilized it over multiple surgeries. The advantages are it is available and affordable, and it is otherwise a waste to the arbiter. And they have similarities to the human eye, which I will just show in the next slide. And this was also reflected from our responses from the participants. So human eye is, compared to the human eye, upper tarsus is a bit smaller, conjunctivine skin is thicker, it has more fat, no bony orbit, puncta is present only in the upper lid, and also other features. There were some difficulties which were present, but they were managed with a larger cutting needle or performing prior canthotomy on the pig eyes. So in conclusion, it is an affordable, useful, achievable model in a resource-constrained training environment, recommended for early training, and all the rubrics once formed, they will have a future application. Thank you.
Meanwhile, can we have, he's here. Can we go to the next the talk that is by Dr. Mihir Tirlok. He's AIOS Himanta Reddy Award winner. He's going to talk about accommodation scale, a ruler gauge for objective assessment of magnitude of accommodation in kids.
Thank you very much for paying attention to this repeat presentation of an accommodation scale. I'm glad to inform you, last month it was presented at American Academy of Pediatric Ophthalmology and Strabismus. This is a scale which you could use to assess the quantity and quality of accommodation of pre-verbal children as young as 6 months of age. I have no financial disclosures to make. It is not uncommon to see accommodative abnormalities in various ocular disorders affecting children, such as Down syndrome, cerebral visual impairment, foveal hypoplasia, children suffering from ectopia lentis, and of course those who have suffered from amblyopia or various strabismic disorders with abnormal AC by A ratios, children with headache, and children who are on low dose atropine to control their progressive myopia. All of them will have abnormal accommodation in as many as around 50 to 80% situations. Currently, the objective methods available are dynamic aberrometry and open field autorefractometry, which are not very clinical, they are research based methods, while dynamic retinoscopy is the gold standard which is used by most pediatric eye surgeons across the world. Unfortunately, this technique has difficulties, learning is also difficult, and having child's attention to do an adequate examination is also difficult. In our survey of 18 pediatric eye surgeons of Mumbai, only one of the pediatric ophthalmologist was confident enough of quantitative assessment of accommodation using dynamic retinoscopy. So, a few years back, we worked on a new technique, which is using a direct ophthalmoscope, ask the child to look at a distance object, and then ask to look at a 40 centimeter object, which is slowly approaching the eye up to 25 centimeter, while the ophthalmoscope is held at meters distance. What you will see in the pupil is an disappearance of a superior bright crescent and appearance of a large inferior crescent as the object of interest approaches the child's eye. This is quite well demonstrated in this particular video, in which when the child is looking at distance, the crescent is superior, and the bright crescent suddenly changes to an inferior bright crescent, and the size of that crescent keeps increasing as the child keeps increasing its accommodation. 1,000 patients data was published in Indian Journal of Ophthalmology in 2014, and then again around 1,000 data points were published using more advanced technique of performing this same thing using a neutralization method with lens interjection. As you see over here, when the child is looking at 40 centimeter and there is an inferior crescent, you can neutralize it with minus 0.5 diopter, and while looking the same child at 25 centimeter, you could neutralize it with 3.5 diopter, indicating the amount of accommodation child is exerting. So in this study, we wanted to create a scale and then validate it. The scale was created like this. The emmetropic child was asked to look at a distance, a 10-year-old child, and lens interjection was done to simulate the amount of accommodation that will be exerted using 0.5 increment of plus lenses. And it allowed us to create this kind of a scale as you see over here. And in the past, ophthalmology has seen multiple such scales, such as pupil gauge or the gauge for cup disc ratio, AV ratio, etc. We had to have 15 patients in our sample for 80% power of the study and 5% significance level. We included 5 to 16-year-old children with normal ocular and systemic health. Our pediatric oriented optometrist first performed this technique, which we coined as estimation dynamic distance direct ophthalmoscopy using accommodation scale and minimal estimation method, which is a dynamic retinoscopy method. And when we compared, we found accommodation scale to have better values at 33 and 25 centimeter versus the current gold standard, and correlation coefficient was excellent between two techniques. We also validated the same scale among pediatric eye surgeons of the city, and we found at the end of the validation, most, say 16 out of 18 members were able to confidently assess using this particular scale. The only limitation I find with this particular method is it is still derived from lens interjection method, and using an app based evaluation like GCK app could make it easier. So in conclusion, accommodation scale is a new armamentarium available in measurement of accommodation for children, and it's quite quantitative and qualitative assessment technique for binocular assessment of accommodation in children. Thank you very much for your attention.
Thank you, Dr. Meher. Now, can I invite Dr. Naren Shetty, and his paper is winner of AIOS Shiv Prasad Hardia Award. He's going to talk on 3D corneal diameter profiling and AI-based sizing for ICL implants. The other speakers are ready. Dr. Naintara Chauhan. If Dr. Naren, if you are going to take time, can we invite Dr. Naintara? Yeah.
Good morning, everyone. Sorry for the delay. First, I want to thank AIOS and APA for giving me this opportunity. Now, I have no financial disclosure according to this talk. All okay? Yeah. So I'm sure each one of us had days where we have done a perfect surgery. We have calculated the perfect size of ICL or IPCL, and then we have done the perfect surgery, and then the next day you see the patient is very happy. You're seeing the vision also is perfect, IOP is normal. But when we see in the slit lamp or in the OCT, you see a high vault and a low vault. Sometimes these situations happen. Now, why does these situations now and then you have these vault surprises? Why does it really occur? This occurs because we rely too much on the horizontal wide to wide. And we do certain assumptions that the horizontal wide to wide is always the maximum and vertical wide to wide is always minimum. So can we have a better way to predict the vault, if not for what is already existing? So what we did is we took the pentacam densitometry scan, we plotted the 256 grayscale, and then we saw the rate of change of densitometry, and then we perfectly marked the wide to wide at 360 degrees and took all of this data and plotted it. What was interesting was we found something, more of an incidental finding, that the shortest wide to wide correlated perfectly with the axis of the, astigmatism. So that is a very interesting accidental finding what we found, and this is something that we even published. Anyway, moving forward, very similar way, we got all these values by, the max and minimum wide to wide, max minimum angle, horizontal wide to wide, and vertical wide to wide. Now we took all these data, also other parameters of the pentacam, refraction, ICL parameters, UBM vault size, all of this, and we put it into AI, and then we found something very interesting. Basically, with the new estimated postoperative vault, the coefficient of determination, or R square, was 0.74. So, for instance, basically the closer it is to 1, that means the better it's performing, and the interclass correlation coefficient was 0.92. Again, closer to 1, that means it's performing better. Now let's look at all the formulas and its R square, how it performs. It can range from 0.3 to 0.4, and the best right now is the Lasso formula, which R square is about 0.68, and our formula is even better than that. So basically, with the novel 3D corneal diameter profile and AI-driven ICL sizing, we're able to have better vault prediction, and also the coefficient of determination, or R square, was 0.74, and the interclass correlation was 0.92. Thank you so much for your time.
Thank you, Dr. Naren. Very nice paper. Now I'll invite Dr. Naintara Chauhan. Yeah, and she is going to, her paper is Sensory and Motor Outcomes After Surgery in Intermittent Divergence Squint. Meanwhile, Dr. Marushka Aguar is here. Yeah, you can join on the other podium. Yeah, Dr. Naintara, please.
Good morning, everyone. I'll be speaking on the topic sensory and motor.
Mic, come closer to the mic. Yeah.
Good morning. I'll be speaking on the topic sensory and motor outcomes after surgery in intermittent divergent squint. So IDS is an exodeviation which is controlled intermittently by the fusional mechanisms. Out of all the exotropia, IDS comprises about 50 to 90% of the cases, and it is preceded by a stage of exophoria. So with the progression from exophoria to exotrophia, there is ongoing deterioration in the stereoacuity. And the clinical severity is measured using the Newcastle control score. So our primary objective was to see the distance in near stereoacuity, and the motor outcomes were seen using Newcastle score and fusional versions. And secondary objective was to correlate the sensory and motor outcomes and to compare these parameters between cases and controls. So 34 cases and 34 controls were taken, and the subjects were examined on day 1, 1 month, and 3 months after the surgery. These were the inclusion and exclusion criteria. So coming to the results, when we compared the cases and control, there was a significant, in cases, the stereoacuity was significantly lower as compared to the controls in near stereoacuity and on distant stereoacuity. And after surgery, we saw that there is a significant improvement at 1 month post-surgery, and then it continues to improve over the next 3 months. But even at 3 months, it was significantly lower than the control in near and distant stereoacuity. For motor outcome, it was drastically improved at 1 month post-surgery and it was maintained over 3 months. Near fusional convergence, that also improved significantly. And to see the correlation between the motor and sensory outcomes, we saw that the correlation was better in pre-operative period as compared to post-operative period. And pairwise comparison showed that there is poor gain in stereo acuity if the surgery is done when the Newcastle score deteriorates beyond 5. So the main conclusion was that cases which had modified Newcastle score more than 5, they had poor prognosis in terms of gain in stereo acuity if the surgery is done later. So surgical intervention should be planned earlier before the stereo acuity, before the Newcastle score deteriorates beyond 5 in these patients. Thank you.
Thank you, Dr. Nayantara.
So for the next talk, I would like to invite Dr. Marushka. She is an AIOS Prem Prakash Award and Disha Award winner. The topic she is going to talk about is third nerve palsy, medial rectus resection versus fixation to the medial palpebral ligament.
Thank you, sir.
Dr. Chenmai is there?
So we know that the surgical management of oculomotor nerve palsy is challenging. It requires meticulous surgical planning. There is no clear consensus about treatment, and long-term surgical undercorrection is common. Our aims were to compare the results of lateral rectus deactivation combined with medial rectus resection and combined lateral rectus deactivation with medial rectus fixation to the medial palpebral ligament performed in the same operative session for total oculomotor nerve palsy in terms of successful alignment and ocular morbidity. It was a retrospective analytical study carried out between Jan 2006 to June 2020 at Arvind Eye Hospital, Madurai. We had a total of 35 patients. All our patients with complete oculomotor nerve palsy with large angle exotropia, more than 50 prism diopters, underwent lateral rectus deactivation of the affected eye. In group 1, this was combined with medial rectus resection. In group 2, it was combined with MR fixation to the MPL. We included all patients with complete oculomotor nerve palsy with a follow-up of at least 6 months after diagnosis. We excluded patients who underwent prior strabismus surgery or those with neurological abnormalities. All our patients underwent a detailed ophthal evaluation, including oculomotility testing and measurement of the deviation. FDT and FGT in clinic was done for all adult patients, and intraoperative FDT was done for all patients. All patients were operated under general anesthesia by a single surgeon, and we measured the ocular deviation on postoperative day 1 and 6 months. Our success criteria was defined as horizontal deviation of less than or equal to 20 prism diopters in primary position at 6 months post-op. So for LR deactivation, after isolating the lateral rectus, we secured it with 5-0 non-absorbable polyester suture and disinserted it from the globe. A hockey stick incision was then made over the lateral orbital rim, exposing periosteum. The posterior tenons was opened, LR was retrieved and secured to the periosteum, and the posterior tenons was closed. In the first group, we combined this with 10 mm of medial rectus resection. In the second group, we combined it with medial rectus fixation to the MPL. So after identifying the medial rectus and the insertion of the medial palpebral ligament, we secured the insertion of the medial palpebral ligament with its periosteum with 5-0 polyester suture. We then threaded an empty semicircular needle through the skin, through the conjunctiva to emerge above and below the medial rectus. We passed this non-absorbable suture through the semicircular needle and secured the upper and lower pole of the medial rectus, and we fixed the eye in 10 degrees of esotropia. So we had 20 patients in our resection group, 15 in fixation group, and an age range of 3 to 65 years. If we see on post-op day 1, both groups performed excellently at correcting the exotropia, but at 6 months post-op, only 65% of group 1 as compared to 93% of group 2 were able to maintain this deviation. If we see, our results are not statistically significant. What was statistically significant is the residual exotropia at 6 months, with group 2 performing much better than group 1. We did not note any significant post-op complications in the resection group, but in the fixation group, we saw one patient who had persistent medial conjunctival congestion and a second patient who had a suture granuloma at the MR site. So these are the pre-operative and 6 months post-op pictures of LR deactivation with MR resection. And this is LR deactivation with MR fixation to the MPL. We saw that in the first group, it was a technically simple procedure. There were no important structures present laterally. Post-exotropic drift could be due to slackening of the medial rectus, and there was less severe limitation of ocular motility. In the second group, it was more difficult with extensive tissue dissection. There was poor cosmesis. Lacrimal sac and angular vessels could be injured. There was persistent epiphora and severe limitation of motility post-op. Our limitations were that randomized controlled studies would better assess the efficacy of each procedure. Post-operative drift beyond 6 months was not taken into account. The number of patients in each group were different, and due to a relatively small sample size, our results were not statistically significant. So in conclusion, we'd like to say that both techniques provide good reconstructive correction of large angle exotropia in complete oculomotor nerve palsy, but we found that lateral rectus deactivation with MPL fixation, though requiring more time and surgical expertise, prevents a long-term post-op exotropic drift better. Thank you.
Thank you, Dr. Marushka. Now we have Dr. Chenmai is not there. So Dr. Maria Banu. And I'll also invite Dr. Harsha on the other podium. Yeah. Dr. Nibha is there. Dr. Maria Banu is going to talk on tail of two traumas, visual outcome in closed globe injuries with and without head trauma.
A very good morning. I thank the scientific committee for giving me the opportunity to present my work once again. I thank my respected co-authors for being with me. Ocular trauma has a wide variety of presentation ranging from contusion to globe rupture and the patient presenting with a vision of 6/6 to patients with no PL. The aim of our study was to analyze the influence of head trauma in the visual outcomes of patients with ocular trauma. It was a cross-sectional study with a study duration of 3 months. We included 300 patients with closed globe injuries attending both our ED and ophthalmology OPD in a tertiary care hospital. We subdivided the 300 patients into two groups, as first group which had 150 patients who presented with both an ocular trauma as well as a head trauma. And the group 2 patients had only an ocular trauma which was a closed globe injury. The age group which was included was 18 to 65 years and the 300 patients as mentioned earlier. Exclusion criteria: patients with severe head trauma with GCS less than 9 and open globe injuries were excluded from our study. The visual acuity during the first admission after trauma and at the end of 2 months was recorded. There were several concomitant factors like head injury, a lid injury and bony orbit was documented, and we analyzed whether they had a effect in the visual outcomes in both the groups. Results: coming to the demographic data, the predominant age group in both the group 1 and group 2 was less than 30 years and majority of our population was only the male gender in both the groups. This graph shows the various causes of closed globe injuries, which shows that both in the group 1 and group 2 the major cause of trauma was a road traffic accident, and this summarizes the various ocular manifestations with which the patient presented. The highest was papilledema in our study in group 1. We also further analyzed whether there was an impact of GCS on visual outcomes. So this table shows that the patients with a moderate head trauma of GCS 9 to 12, approximately 38.9% of the patients had an improved visual acuity more than 6/18, whereas patients with a mild head trauma, which is GCS more than 12, about 56.5% of the patients showed an improvement in visual recovery. We also analyzed whether the visual outcomes in patients with papilledema in group 2, in group 1 it was about 27.3% of the patients had a visual recovery of more than 6/18, whereas in group 2 it was 100%. The 5% in the group 2 had papilledema, which could be probably explained by the bilaterality of the ocular trauma. The exact origin of the papilledema may be due to an head injury which was not evidenced by any radiological investigations. Incidence of RAPD was also taken into account. In group 1 it was about 42 patients who presented, whereas in group 2 it was 21. Further, we analyzed how does RAPD affect the visual outcomes in patients. In group 2 the total was 21 patients and we see that it was an intraorbital injury or canalicular injury to the optic nerve. Of these, 6 people did not show any improvement and 15 showed improvement. We also did an optic nerve decompression was done surgically, but visual outcomes did not improve for the 2 patients. We also saw whether there was a concomitant bony orbit involvement which is affecting the visual outcomes. In group 1, it was a blowout fracture which was most common, whereas in group 2, it was a medial wall which was the most common fracture, and it also shows the visual improvement. Visual outcomes in patients with lid improvement, approximately 56% of the patients in group 1 and 75% of the patients in group 2 showed an improvement in visual outcomes. So coming to the final discussion and summarizing all the things, presence of head trauma in patients with papilledema had a poor prognostic factor and it was statistically significant. Presence of RAPD in patients with head injury had also had poor visual outcomes, which was also in correlation with the previous literature studies which showed that RAPD grades were also associated with poor visual outcomes. We also found that bony orbit involvement affected visual outcomes in both the groups, but results were statistically insignificant. Lid injury was also noted and the results were statistically significant. Coming to the conclusion, we conclude that head trauma, when happens along with ocular trauma, has a basically important prognostic significance. GCS score is an important factor in assessing the general prognosis. Presence of papilledema in the presence of head injury is a grave prognostic factor. RAPD in association with head trauma is an ominous sign. Bony orbit involvement, if present along with a concomitant head injury, decreases the visual outcomes, even though it was statistically insignificant. Lid injuries do not decrease the visual outcomes, irrespective whether there is a concomitant head injury or not. So we conclude that papilledema, RAPD and bony orbit involvement are the factors which predicts the visual outcomes in patients who present to you with a concomitant ocular trauma as well as a head trauma. These are my references and thank you.
Thank you, Dr. Maria.
For the next talk, I would like to invite Dr. Harsha P. She's the AIOS Nursing Rao Award winner. She's going to talk about an important topic, that is the sarcoidosis tuberculosis conundrum, the role of serum ACE, Montuxdex and lymphocyte count. Over to you.
Good morning, everyone, and thank you for the opportunity. Ocular tuberculosis and sarcoidosis are two diseases with very overlapping clinical features, and hence differentiating one from the other is a challenging task. Now, they are even postulated as opposing presentations of the same disease spectrum. Even though conventionally serum ACE is seen to be elevated in sarcoidosis, there is a lot of overlap, and also sensitivity and specificity of serum ACE, MAN2, and lymphocyte count vary in different study populations. So the studies depicting their utility in combination are scarce and are quite relevant in TB endemic countries like India. Now, the purpose of the study was to evaluate the diagnostic utility of serum ACE, MAN2 test, and lymphocyte count, both in isolation and in combined, in the diagnosis of ocular tuberculosis and sarcoidosis. The outcomes were sensitivity, specificity, positive and negative predictive value. This was a prospective observational study which happened for 2 years in UVA clinic of Aravind Hospital, Pondicherry. We had 95 patients with acute uveitis of age more than 18 years, and we excluded patients with history of trauma, immunosuppression, and patients on ACE inhibitors. Now, the diagnostic criteria used was revised IWOS criteria for sarcoidosis and the Gupta et al. Criteria for ocular TB. We had 95 patients with a mean age of 44.52, and out of 12% of the total study population had ocular tuberculosis, and 20% of the study population had sarcoidosis. Now, serum ACE was found to be elevated in 89.5% of the sarcoidosis sample and only in 33% of the ocular TB patients. Now, the mean value was 76 in sarcoidosis and 50 in tuberculosis, which was statistically significant. MAN2 was elevated and positive in 58% of the ocular tuberculosis patients and only in 15% of the sarcoidosis patient. The mean value was 12 in TB and 2.95 for sarcoidosis, which was significant. Now, lymphopenia was seen only in the ocular sarcoidosis group, and none of the other groups had lymphopenia. Coming to the sensitivity, specificity, and the predictive value, elevated ACE had a very good sensitivity and negative predictive value in diagnosing ocular sarcoidosis, and also negative MAN2 test also had a good sensitivity and negative predictive value. Since we had only one sample with lymphocyte count less than suggestive of lymphopenia, the specificity and PPV became as high as 100%. Now, in ocular TB, non-elevated AC and elevated AC both had a very good negative predictive value. This was an interesting finding, and also positive MAN2 had a very good negative predictive value in diagnosing ocular TB. The ROC curve for sarcoidosis for serum ACE was 0.819 and was statistically significant and better compared to that of negative MAN2 and lymphopenia. And for ocular TB, the positive MAN2 had an AUROC of 0.835, which was significant. Coming to the strengths of my study, this was a prospective study where screening was done by a single trained observer in a single tertiary eye care center. To the best of our knowledge, no study conducted so far tested the combined utility of elevated ACE, negative MAN2, and lymphopenia in the diagnosis of ocular sarcoidosis. The study also analyzed the utility of serum ACE in ocular TB. Now, coming to the limitations, this was an observational study without any randomization, and also study period included the peak phases of COVID-19 pandemic, so viremia due to coexisting or previous infections could have affected the lymphocyte values. There were no biopsy-proven cases. Subjects included were presumed or probable sarcoidosis and probable or possible ocular TB. A similar study by Ilangar et al. From South India says elevated ACE was an independent risk factor rather than this in combination, but a study by Philippine Court et al. Says combination improved the diagnostic performance. So the day clinic message is combination of elevated ACE, negative MAN2 and lymphopenia had a better ability to diagnose ocular sarcoidosis owing to high specificity and positive predictive value than these tests in isolation. As the NPV is very high in subjects with normal ACE, further screening tests for ocular sarcoidosis may be required only if clinical suspicion is high. Even though serum ACE was elevated in some patients with ocular tuberculosis, it may not serve as a useful screening or diagnostic tool in the detection of ocular TB. As the NPV is very high in case of negative MAN2, further screening investigation for TB may be necessary only if there is a strong clinical suspicion. Serum ACE level assay is a better test for discriminating ocular sarcoidosis cases from the other diagnosis, and MAN2 test is a better test for discriminating ocular TB from other diagnosis. Thank you.
That's a very nice talk. Just have one or two questions that I have for you. Number one is, what's your take on CECT or HRCT while differentiating between sarcoidosis and tuberculosis?
So HRCT would be an ideal investigation where we see bilateral hilar lymphadenopathy, but for our population, like those people who are willing for HRCT, we had relied on HRCT, but there were a few who are like financially not viable to take an HRCT, so we took chest X-ray instead of HRCT. But also the bilateral hilar lymphadenopathy documented on chest X-ray. CECT would be a better, it's one of the diagnostic criteria in IWOS, and in they mentioned HRCT as one, bilateral hilar lymphadenopathy and HRCT as one criteria for the diagnosis.
So solely relying on the ACE levels as well as the MANTOX, you're right that MANTOX is because of the energy that happens in sarcoidosis. The MANTOX is usually not that high, or it is non-reactive.
Yes.
However, in a cases of tuberculosis, although we are in an endemic region of tuberculosis and we have been all vaccinated, so it usually don't go up beyond 15. So if it is more than 15, it is probably you're looking at TB and not a sarcoid patient.
Yes, sir.
And if you have an ACE, so what is the ACE level that you have found to be cut off for your study that this is doubtful ACE and this is
We took the
confirmatory ACE?
cutoff as 52.
Okay.
The main reason for this study was that there's this new hypothesis saying tuberculosis and sarcoidosis to be the part of its spectrum, where Mycobacterium tuberculosis is also the etiological agent responsible for sarcoidosis, especially in endemic countries.
Okay.
So the study states that they propose that in endemic countries like India, patients with ocular sarcoidosis might have Mycobacterium tuberculosis infection in a latent fashion, but because their immunity is very high, they don't have features similar to that of the ones with ocular tuberculosis. So that is why we wanted to test whether there is an overlapping pattern. So we conventionally we think ACE is elevated in sarcoidosis and MAN2 is like negative in sarcoidosis, but we could get samples with positive MAN2 in sarcoidosis as well. So we think there is an overlap as well.
But I think doing in CECT in these patients is going to be the more diagnostic rather than these tests itself.
Definitely.
Thank you.
So now we have Dr. Nibha Mishra, and her paper's title is Advanced Glycation End Products are Biomolecular Biomarkers of PDR.
Good morning. At the outset, I'd like to thank AIOS Scientific Committee and my mentor, Professor Sandeep Saxena, for supporting me in my research. My research title is Advanced Glycation End Products are the Biomolecular Biomarker of Proliferative Diabetic Retinopathy. We all know that we live in a world where diabetes mellitus has grown to an epidemic level, with diabetic retinopathy, a major neurovascular complication affecting the functional group of population with vision-threatening complications. So no stone has been left unturned to understand the pathogenesis of diabetic retinopathy. In this, what we have studied is been known and has been studied as one of the major triggering biomolecule for all the pathogenesis. So what happens? Hyperglycemia. It leads to a non-enzymatic glycation reactions, which leads to an irreversible damage to the structural and functional integrity of our basic skeletal framework of our body, that is proteins, lipids, and nucleic acids. Where comes the concept of metabolic memory, which states that even after the reversal of hyperglycemia, this damage is permanent. So that leads to the generation of advanced glycation end products, and the molecule I will be studying or stating to you is about N-carboxymethyl lysine, which is one of the commonest one. As earlier stated, we will be studying we studied the role of ages as a biomolecular biomarker for proliferative diabetic retinopathy. In our study, it was a cross-sectional tertiary care center-based study, and we divided the study into 3 groups with no diabetic retinopathy, diabetic NP non-proliferative diabetic retinopathy, and PDR. All of them were 40 to 65. Age and sex match controls were taken. What was the exclusion criteria? All the retinal, any patient with existing retinal vascular pathology prior treatment, patient should be treatment naive, or any condition where NCML, the ages levels are supposed to be high, were excluded. A detailed data collection was done, including demographic details, and all the clinical data was taken. The blood investigation was done with special emphasis on the serum glycemic profile and the assay of NCML. The serum NCML was done by quantitative sandwich enzyme immunoassay technique. The relevant statistical analysis was done, and our power of a study was 94%. In the results, I like to highlight the main things that our study, all the groups were age and sex matched. The duration of diabetes in the NPDR group and PDR group was was comparative, and no significant difference was there. The NCML levels were rising in the groups as we proceeded from the severity from control to proliferative diabetic retinopathy. But what is noticeable is that the glycemic status, if we see NPDR and PDR, the HbA1c levels were not significantly different. This is what the scatter plot shows about the NCML and the visual acuity, the functional changes which we saw with the severity, the visual acuity decreased. That is, with the increase of NCML, the visual acuity was decreasing. So coming on to a major analysis was the receiver operator characteristic analysis. On AUC analysis, what we found was, if we see this chart of ROC curve analysis, on the vertical axis we have the sensitivity, and the horizontal axis we have the specificity, and the AUC for PDR is coming out to be 0.842, which is quite significant for a diagnostic tool. So the ages range axis leads to continued cellular dysfunction. Ages cause retinal pericyte apoptosis, stimulate VGF. Ages trigger oxidative stress, and even now they are the new therapeutic targets for diabetic retinopathy. So why we are going towards something different rather than HbA1c is there are genetic variants which affects the HbA1c level. There are chemically modified erythrocyte survival rate affects them. So they do not actually sometimes shows us the actual glycemic control. So in conclusion, I would like to say that ages are the major biomolecular biomarker stating the pathophysiology of evolution of diabetic retinopathy. They are the novel therapeutic targets. They are new age tools of translational medicine. We were able to publish our research in AIOS. Thank you.
Thank you, Dr. Neba.
Thank you.
That's a very interesting development. So they not only tell us which patients are going to develop the advanced disease, they also give us therapeutic target also.
Yes, sir. The
so that we
predictors.
can target these advanced glycation and
Yes,
products.
yes, sir.
Yeah. Okay. Thank you. So with
Thank you.
that, we come to the end of the session. I'll invite all the speakers to come for a quick group photo.